All right, ladies and gentlemen, welcome to week number 5 of GCH 604. You've made it through more than a quarter of the course now, so congratulations. Unless, of course, you haven't done the quizzes and, you still have a bit more work to do. But yeah, we're a quarter of the way. We're moving along quite well. From what I see in the quizzes, you all are doing great. I will have the first office hour on tomorrow. I'm recording this Sunday the 18th, so 9, 19, 22 at 8 p.m. Eastern. We'll have the first office hour. What I'm going to do is I'm going to take any questions from you if you have any questions. If not, then I'm going to do a very quick lesson on installing R Studio in your computer, and then some very basic things that you can do with R in as much as like doing some basic math operations, some basic descriptive statistics, but not too deep. And then for the second half of the course, what I'm going to have is I'm going to have exercises that will go along with the lessons. So you'll watch the lessons, you'll watch the lectures, look at the slides, do your readings, and then you'll do those exercises in R Studio, and we'll go over them. And when I have the office hours on Mondays as well, and then you'll answer some questions in the quizzes that have to do with those exercises, and that will be your introduction to biostatistics and your practice in biostatistics. Again, fundamentals, very high level stuff. You won't have to compare the means of four groups. You won't have to do non-parametric biostatistical testing. Very basic comparison of means, comparison of proportions. How do you know if what you're looking at is based on a happy accident, or actually there is a difference, and p-values and all of that stuff, all of that good stuff. So let's get started with week number. So week number 5, we were talking all about general health and population indicators, a lot of rates, a lot of how do we do things, how do we explain things. And one of the things that you need to understand is that disease occurs on a spectrum, right? This is the spectrum of substance use disorder, or opioid addiction, or any kind of addiction, really. On the left hand side of the spectrum, you have abstinence. Somebody doesn't use a drug, doesn't use the chemical, doesn't use alcohol, doesn't drink, doesn't smoke, doesn't inject any drugs. And then you move into the beneficial. Sometimes you need to take medication. Sometimes you need to take drugs to feel better. So if this is the opioid addiction, then sometimes you need the painkiller for a bad injury, so you can actually not keep injuring yourself, or you can actually be functional and work. Then you get into the non-problematic use. So you're past the beneficial use, and now you're kind of using it because it feels good, right? If drugs didn't work, nobody would use them, and so drugs work and people use them. So here we are in the non-problematic part. It's not interfering with work, it's not interfering with your life, your daily living. It's not a problem. It's on its way to becoming a problem, right? And then that's when we get into the potentially harmful, the problematic stage. Potentially harmful because you could overdose, it could hurt you, you could get infected with HIV or hepatitis C, hepatitis B, hepatitis A if you're injecting drugs, etc. And then you finally get into the substance use disorder, where it interferes with your life, it interferes with work, it interferes with family, it interferes with activities of daily living, it interferes with your health. You probably have some other comorbidities going on. It's a problem. In public health, we try to stop things along the way, right? If you're not using drugs, we don't want you to start. If you are using them for medication, we don't want it to get into the non-problematic use. If you're a non-problematic, we don't want it to get into the harmful. If it gets into the harmful, we don't want it to be a substance use disorder. If you're in the substance use disorder, we want to drive you in the opposite direction, right? And we also want to drive you in the opposite direction along the other ways. But understand the disease occurs on a spectrum, and that's why a lot of these rates are based on case definitions, and understanding the numerator, what the definition of a disease or disease condition is, and then the denominator, the population. So life expectancy. There's a few videos in the in the lecture materials, or actually in the course materials, on life expectancy. Take a look at those, of how life expectancy is calculated. A lot is made out of life expectancy. People like to talk a lot about life expectancy because it gives you the expected number of years that a child born on that year will live, and it is affected a lot by things that happen that are much outside of our control, right? Our individual control. So you see here in the 1918 pandemic, life expectancy dropped by a lot for both sexes. It went from about 55 right here, dropped well below 40. more for males. And it wasn't just the pandemic, also World War One was happening at the time, so that's probably why males dropped so precipitously. Um, World War Two, again, males more affected, but overall life expectancy dropped, not as much as the pandemic of 1918. This drop right here was probably the result of the stock market crash, which happened at the end of 1920, so 1929 of the 1920s, 1921, 930s. This is probably the Great Depression right here. And then the rebound for World War II, the gear up to World War II, the New Deal from FDR, and then World War II happens, and then the economic boom after World War II, the baby boom, things are getting better, and we get to the pandemic, and it begins to drop again. So there are some rates that are mentioned. Growth rate, which is birth rate minus mortality rate. Lower mortality rate equals higher life expectancy. Life expectancy measures growth rate, right? They're related. They're all related to each other. So kind of understand the relationship between mortality rate and birth rate. If your birth rate is climbing, and your mortality rate is not keeping up, you're going to have a growth in population, and that is exactly what happened. The baby boom that happened after World War II, things like that. And I'm going to have to apologize if there is some noise in the background. Again, I'm doing this remotely and from home. We kind of get some background noise. But anyways, let's move on. Health indicators. A health indicator is a marker of health status, service provision, resource availability. So these are three things that I will hint at for the quizzes or the exams. So for example, I might ask you, what are health indicators? What are they markers of? Health status, service provision. So how healthy the population is. Are there enough hospitals and other services to provide things that keep you healthy? And are there enough resources to provide those services to keep you healthy? Okay. You combine the indicators called into an index, and when we combine them, we call them an index. So, we might put things together to come up with some sort of health index or vulnerability index. I always have problems pronouncing that word. Pronouncing that word. So when you put things together, you call them indices or index singular. I will talk a little bit more towards the end of the lecture about that. So health indicators are mandated by law in most parts of the world. Certainly in the United States, we have civil registries that record every birth, every death, and we sometimes also keep records of diseases, right, like cancer registries. We also are keeping track of the number of COVID-19 cases. So the law tells us to keep all these records and keep track of it because it's helpful to know where services are needed, who's getting sick, who's dying, why are they dying, what can we do to stop that from happening, etc., etc., etc. So this is a death certificate. If you take a look, it's in the CDC. CDC has a standardized mortality report or a death certificate, and then the birth certificate as well. So a little bit more about life expectancy. The average years a newborn is expected to live is life expectancy. But you can see that this is kind of tricky, right? Because you're kind of predicting the number of years that somebody might be born without actually taking into account their health, where they are being born, their environment, what could happen in the future, etc. Assuming mortality rate at time of birth is the same at time of death. But that's not always the case, right? Think about that a little bit. Like I said, things could happen and it could mess with the mortality rate could increase. A pandemic comes along and that messes with life expectancy. So it would be more meaningful for someone who already has lived to a certain age to know how much more time they have, right? So for example, somebody who has lived to 40s and they're non-Hispanic black male, right? Their life expectancy or their years left to go is somewhere about 38. So it's about 78 total. It's a little bit higher. There are inequities and inequalities. Hispanic females living the longest. So a 40-year-old Hispanic female is expected to live another 46 years, I'd say, until they're at 86. Look at this disparity, right? You see it all over the place, over and over again. Baltimore City, there are some neighborhoods in Baltimore that have life expectancies in the 40s, right? And others are in the 80s. And that's just a problem with the system and the delivery of healthcare systems and the resources, which are all measured by indicators. So, how do we measure birth? The main thing that we use to measure birth is birth rate, which is the number of live births during a specified time period, usually 1 year, divided by the population from which the births occurred, multiplied times 1,000, right? Birth rate is influenced by government policies. So if the government gives you more taxes, gives you more breaks on your taxes, if you have more children, you're probably going to be inclined to have more children. If the government is making it hard for you to survive, you're being persecuted. You're being treated as a second-class citizen. You're probably not gonna want to have more kids, right? Religious beliefs, right? Certain religions believe in having more children. More children, the better. Other religions are not as, proposing of having big families. The environment goes without saying. If you don't live in a good environment, you're probably not going to have more kids. Economics. This is an interesting one. It's a paradox. If you are better off economically, chances are you're not going to have as many kids. If you're worse off economically, you're going to have more kids. That's because of access to reproductive care, access to contraceptives, etc. And so this is an interesting paradox that we always see in public health. Childhood diseases, less childhood diseases, higher births, right? More births. If your children are dying before they're 5 from polio or from measles, you're probably not going to want to have more kids. Or if you need to have more kids to run the farm in some developing nation, then you're going to have more kids, but they're not gonna make it. You're gonna have a higher birth rate, but they're not gonna survive long enough. Access to healthcare goes without saying. The better access to healthcare you have, the slightly better the birth rate is. But the paradox there goes with economics, that if your access to healthcare includes access to contraceptives, you're gonna have less babies being born, and so on and so forth. So it's not straight up an indicator of economic wealth, as we can see. It's also an indicator of all these other things. So it's an index in itself a little bit, right? Fertility rate. So fertility rate, the number of live births during a specified time period, usually a year, divided by the population of women of childbearing age, in this case 15 to 49. In some places, the childbearing age has expanded a little bit to be like 13 to 52 or something like that. But we use the standard. This is kind of the international standard, 15 to 49. And then the age-specific fertility rate. So the number of births in a given year to women of a certain age or age group, that's also acceptable, divided by the number of women of that age group or age at the mid-year. Right? Because if for example, in 2001, you were in January 2001, you're 20 years old, but your birthday's in June, you're going to turn 21. So what they do is that they want it at the midpoint. So on June 30th, that is the midpoint. How many people or how many women of that age were alive at that point? And then you have the total fertility rate, which is the age-specific fertility rates times 5 in 5-year age bands from 15 to 49 divided by 1,000. Okay, and that's that just kind of breaks it down for women. According to the Population Reference Bureau, this is the average number of children a woman would have, assuming that current age-specific birth rates remain constant throughout her childbearing years. So it's kind of asking if a woman between 15 and 49, right, how many kids would she have? And that's kind of the estimate. This map is really interesting. This map shows the fertility rates in the world, and you can see again the interplay of economics, culture, society, etc. Higher fertility rates in Africa, right? But not in the countries in Africa that are doing better than others. So in South Africa, Egypt, the northern countries. Morocco is a little bit of an outlier. It's not as populated, so it probably doesn't have that many people being born there. But the wealthier countries, right? The superpowers, United States, Russia, have low fertility rates. The well-off countries New Zealand, Australia, countries in Europe, uh, and then you have the super low fertility rates, right? China, with their one-child policy. Japan as well. Japan is in trouble. Japan needs to bring in a lot of people to take care of their aging population. They're not replacing a lot of countries in Europe as well. Spain, um, Italy, not East of Germany, Poland, the countries in the old Warsaw Pact. They're in trouble. They need immigrants, and they're trying to keep out a lot of immigrants, or at least not bringing in people. But they're going to need them, and the United States is marching towards that. Again, the better a country does financially, the less you don't need as many kids to keep you healthy. You don't need as many kids to run your farm if you have a farm. And so you're seeing this, and the fertility rate is also dropping. Chile, Paraguay, you're seeing it coming down. Cuba, because those countries are getting better financially. So it's an interesting exercise in the questions of why some countries see lower fertility than others. By the way, Greenland is part of Denmark, right there. This is Iceland. So the gradation, it could be a little bit better on this scale, but overall, the better a country is financially, the lower the fertility rate. That is why Africa, with so much historically taking out of it in terms of resources and people, they're making up for it with having a lot of babies. Africa will have maybe almost 2.5 billion people, when other countries will be well below 1 billion. Not other countries. Africa is a continent. When other continents are gonna be below 1 billion. China is on its way down. India is on its way down. North America, South America, etc. Contraceptive prevalence. So the number of women of reproductive age, again 15 to 49 in this case, at risk of pregnancy, so women who have uteruses, who have not undergone some sort of surgery to remove their uterus, who are biological females, right, who are using or whose partner is using a contraceptive method at a point in time, divided by the number of women of reproductive age at the same time point. Okay, so you see this, and the question that I ask, and again, this is another hint for you for your midterm and for your quizzes. What would influence contraceptive prevalence? Government policies, availability of the contraceptives, cultural considerations, religious considerations, societal considerations, right? All those things, your access to healthcare, all these things come into play on contraceptive prevalence. And you see here the contraceptive prevalence in 2015. Percentage of women using any method of contraception among those aged 15 to 49 who are married or in a union in 2015. And this is just married women or in some sort of a union. Big bias right there, right? Women who are not in a partnership are probably more likely to try to use contraceptives because they're on their own, and they're not going to raise a child all on their own, right? And again, you see the map. This looks a lot like the fertility one, right? Countries that are not as well off financially will not have as much contraceptive use, which drives the birth rate up, right, from the other slides. Countries that are better off financially are going to be having a high prevalence of contraceptive use, right? But there are also cultural considerations. There might be a country that doesn't allow contraceptives. There might be states within countries that are messing around with access to contraceptives, right? And so, again, think of all the biases and all the things that can go into these numbers, because when you are calculating these numbers and explaining them, you need to explain all those caveats. When we talk about mortality, it is important to know the difference between main cause mortality and underlying cause mortality. So the main cause of death versus the underlying cause of death. The underlying alone did not cause death, but it didn't help either. So for example, COVID-19 might kill somebody with an underlying lung disease. Without the COVID-19, the lung disease alone would not have killed the person at that time. It could have done it later on. The person could have gotten better, right? COVID-19 came along and killed them. So in that case, COVID-19 would be the main cause of death, And then having the lung issues would have been the underlying cause of death. Same thing with heart disease, etc. ICD-10 codes have been designed to standardize the disease diagnosis. It's the International Classification of Diseases. It's not universally used, but more and more countries are adopting it. But the question is, what about places where a trained person cannot ascertain the cause of death? And there's some places in the United States where the medical examiner doesn't exist, and it's a coroner, and the coroner is elected by the people, and it doesn't have to be somebody who has any experience in telling whether or not somebody died by X or Y reason. And so this is an interesting paper, Suicide or Undetermined Intent, a register-based study of signs of misclassification. There is good evidence to show that deaths due to suicide are being classified as accidental or some other thing, or that deaths that are accidental or happens for some other reason are being classified as suicidal. That's kind of one of the things that we need to keep in mind when we talk about mortality. Big hint, again, for your quizzes and your exams. So what are the measures of mortality? Crude mortality rate, the number of deaths during a given time period, usually 1 year, divided by the population from which the deaths occurred. The cause-specific mortality rate is the number of deaths from a specific cause during a given time period, usually a year, divided by the population from which the deaths arise. Okay, so there's a difference between crude mortality rate, cause-specific mortality rate. Crude is just everybody dying. Cause-specific is everybody dying from a specific condition. Again, big hint, if I mention a specific condition and I ask you what would be the best measure of death for that specific condition, specific is the operating word. In years past, students have missed that, so I don't want to repeat it with you guys. Just know that if I mention specific, I'm talking about cause-specific mortality rate. Big hint. I just pretty much gave you an answer right there. And then you have more measures of mortality. Infant mortality rate, number of deaths among infants, 0 to 1 year during a specific time period. That's the key thing there, 0 to 1 year. Neonatal, new birth, so number of deaths from birth through 27 days of life. Post-neonatal, number of deaths from 28 to 364 days of life. So you can see it's neonatal first, then post-neonatal, and then infant mortality. And then we go into perinatal mortality rate, number of late fetal deaths and deaths in the first week of life, divided by the number of stillbirths plus live births. This is key. Look at that denominator. It's a little bit different, all right, than the previous ones that we're talking about live births. Times 1,000, and then the fetal death rate, number of fetal deaths after 20 weeks of gestation, number of stillbirths and live births. This is probably going to change, given the recent decisions by the Supreme Court, that this is the way that states individually are going to be counting this. It's going to be different. Good luck, because it's hard to tell if a woman has a miscarriage how old the product of conception was, versus an actual more developed fetus, 20 weeks gestation. So 20 weeks is half of the birth, half of the gestational period, right? So we'll see how this changes. But for now, I mean, we're still going to be using this number of fetal deaths after 20 weeks, which is more or less the time of viability, divided by the number of stillbirths and live births. We'll see how this changes. It's going to be very interesting. So maternal mortality rate. This is, again, look at this map. Maternal mortality rate, number of deaths due to the pregnancy state or its management during a specific time period, divided by the number of live births in the same time period. And this is number of deaths in mothers. Okay, this is moms dying. And look at the economic impact on maternal mortality, right? Developing nations just have an awful time with maternal mortality, right? Tied to economics. Lots of women can access healthcare, cannot access prenatal care, cannot access abortions. If the pregnancy is affecting the health of the mother, and they have no access to abortion for government, religious, legal reasons, then they're more likely to die. And you see it here. Within the United States, there are severe differences in maternal mortality between women based on their race and ethnicity, even when adjusting for economics. Women who are Black, African American, will have much higher mortality rates than women who are white, even if they both have the same socioeconomic status. Very interesting to read out more. Very interesting to understand those patterns of why these things happen. they're happening, and then it's up to us in epidemiology to explain why they happen and what can be done about it. Then more measures of mortality, proportional mortality rate. Proportional is the key word here for the proportional mortality rate. Number of deaths from a specified cause during a given time period. Number of deaths in the same time period. All right, proportional mortality. This looks like cost specific, right? Specified cause during the time period divided by the deaths in the same time period. But don't be confused. Here we're talking the number of deaths from a specific cause during a time period divided by the number of deaths. A cause-specific mortality is divided by the total population. So those are two different, and again, that should be a hint for you. Death to case ratio, so the number of deaths attributed to a particular disease during a time period divided by the number of new cases of that disease identified in the same time period. So this is a perfect example for COVID, right? Number of deaths from COVID divided by the number of total diagnoses of COVID, right? The death to case ratio, or case, we also often call it case fatality rate. So you might see it in some others, CFR, in some epidemiological papers. Years of potential life lost. Again, this is another one that is very interesting because let's say that you live in an area, a state, a country, a town, where your life expectancy is 78, and you die at 48. So you had a total of 30 years of potential life lost. So we add these years of potential life lost across everybody who has died in a given year, and those are the years of potential life lost. Okay, so endpoint, your expected life expectancy minus the midpoint of age group before the endpoint times death in any age group, number of deaths. So this is what I was showing. 78 minus 48, right, is 30. And you multiply it to the number of people who died at that age. So let's say that 10 people died at that age. So that's 300 in that age group. And then this is the summation. So you add them all up, and you can have years of potential life lost in the thousands, as you can see on the scale here for New Mexico. And you can have a lot of big differences. The thing to remember here is the interesting thing is this whole situation with age expectancy. So if you are in Baltimore and you are in a neighborhood where your life expectancy is 65 and you die at 40, we are losing, because this is a collective problem, we are losing 25 years of potential life from you. But if you live in a place where the life expectancy is 75 and you die at 40, then we are losing 35. What if it's 85? And so on. So you see where life expectancy will influence this number of years of potential life lost. So a hint for you for the midterm and for the final and for the quizzes is, if I say to you, a young man dies in a county where life expectancy is 75, will you see more or less years of potential life lost than if the life expectancy was 85? The answer is you will see less, right? You would see 30 years instead of the 40 years from the 85 versus the 75. So those are the kind of questions that I will ask. Again, understand that you're adding up all the deaths. So the number of people who died at age 48 in a place that their expected life is 78. So if you have 10, you're going to have 300 years of potential life lost. And you add all of those, you add the people who died at 49, at 50, at 51, at 52. And if they died at 78 or greater, that's another question that students often have. Well, what about somebody who dies at 78? Then their years of potential life loss is 0. Okay? What if they were 79? 0. What if they were 80? 0. You don't add years back. You don't go into the negative. When you hit the expected age and they die, their years of potential life loss will always be 0. So look at this, countries by birth rate in 2017. Interesting stuff, right? The birth rates, again, like I said, dropping in a lot of places, mostly wealthy places, or places that are on their way to being wealthy, or places that are for superpowers, or places that had the one child policy. or places that are very wealthy and technologically advanced and superpowers, right? Taiwan is in there too, technologically advanced. Look at the birth rate. Africa, right? Afghanistan, after the war, their birth rate shut up. After wars, birth rates increase. It's something interesting to look at. Again, countries that are doing better financially, right? And like I said, Japan is in a lot of trouble, and so is Italy, Spain. They need to bring in. They actually are at a point where they need to bring in immigrants to take care of their elderly populations because they will not be able to do it on their own. It's an interesting thing, and from that, from the public health side of things, you're gonna see more disease and disability in the elderly who are not being taken care of, right? The whole access to services. If there's not enough doctors, if all the doctors are retiring, again, some issues there. So finally, the question about the index. So what is an index? So let's say that I want to measure the relative health of a neighborhood, and I want to compare neighborhood A with neighborhood B. And let's say years of potential life lost are 1,500 here and 2,300 there. Then you would say that neighborhood B is worse off. But what about income? What if income was like 78,000 per person here and 43,000 per person here? Then neighborhood A is doing better, right? So here, B is the winner, and A is the winner. What about number of doctors? What if they have 2 doctors per person here, and over here they only have half per person? Then neighborhood A wins. What about hospitals? What if they have 5 hospitals here, but there are 7 hospitals over here? The neighborhood B wins. So you can see it'll flip back and forth, and the way to say which one is doing better is to combine all of these indicators into an index. And the way we combine them is by using a Z-score. And you'll see some videos in the materials on how to calculate Z-scores. What we do is that we say, okay, well, the average is 1,800, and what is the Z-score here? So this Z-score is going to be in the negative, and the Z-score for the 2,300 is going to be in the positive. And we go on down and we add up all the Z-scores, and we have a Z-score at the end, and whichever one has the highest Z-score wins. Because as you can see, right, if you have a higher than average years of potential life lost, I'm sorry, that's something you need to take into consideration. Is this good or bad? So years of potential life lost is bad, right? Having more of them is bad. So you might want to flip the number on the Z here to a negative Z, and this one to a positive Z. So at the end, when you put them together, if it's a bad thing, then it has your Z-score is lower. If it's a good thing, your Z-score is higher. But anyways, you add them all up at the end, and you come up with a Z-score, and that's how you create an index. I will go more into detail in one of the exercises that I will have ready for you. It's just going to be a simple exercise of doing Z-scores in R. And I also wrote a blog post about it, so I'll probably post a blog post too. But basically, it's just taking different indicators of different places, if you're going to compare them, standardizing them so they're all on the same scale, and then comparing those standardized scores. Once everything is on the same scale, then all things are equal, apples to apples, oranges to oranges, and you can compare and see what is the best or the best place to live, or the best place to be alive, etc. So that's what an index is. An index is putting things together, standardize them, and then standardizing them so that they can be comparable between 2 places. I will not require you to do any kind of calculations to calculate an index. I might just give you some questions as to, like, what if we have these indicators? What are the next steps to try to compare them between 2 places? And you would say to me, well, you rank them, and then you get a Z-score, and then you add the Z-scores, and you compare the Z-scores across places. Those are kind of the four main steps. All right. So with that, again, I will see you on the 19th, September 19th at 8 p.m. Eastern time. I will try to record the session and post it for everybody to look at. Again, I will begin by answering questions, and then we'll have a mini, very quick lesson in R, very quick lesson in biostatistics. We are going to get more biostatistics heavy in the second half of the course. We're still going to be heavy on the epidemiology, but I am going to start to introduce you more and more as we go along to R and the things that R can do and the things that R can do with biostatistics. All right, and I'm also going to be doing some lecture videos in addition to the ones with the slides for the readings. I'm going to do some videos on, for example, number theory and why you need to understand number theory, logarithms, things like that before you get into statistics. And that's it, ladies and gentlemen. Thank you so much for your time. I hope you have a good rest of the week, and I will talk to you soon.